Now let us see what are all the drugs. Warfarin, which is an anticoagulant, 33%. Insulin, 14%. Excepting the juvenile diabetic, the adult diabetics require very, very small percentage of them above 80 require insulin. So why should 14% of above 80s have insulin? They all go in for hypoglycemia. Antiplatelet drugs, blood thinners, 13% of emergency. Oral hypoglycemic drugs. After 80, giving oral hypoglycemic drugs only to satisfy the patient, not to lower the blood sugar. It should be given only to satisfy the patient that you are giving a pill. If you lower the blood sugar, the man is sure to end up in the hospital. Then there are many other things, but what they said was very interesting. 12.8% of the US population was aged at least 65 in 2010, a total of 16,000 people, males, and 22,000 senior males. Americans are living longer. Approximately 40% of the seniors between 5 and 9 medications, and while 18% of these people above 65 are at least on 10 drugs. So, as you grow older, the drugs are increasing. One for constipation, one for vomiting, one for sleeping, one for waking, one for body pain, one for lack of body pain, one for so many things. I mean, it is impossible to believe that it's all true, but it is very true. Next slide, please. So, we went into our records. I'm not going to go through all this. You will see the age anywhere between 52, 72, and duration 5 years, 3 years, 1 year, 5 years, 20 years is also there. Various symptoms here are there, many of them caused by drugs. If you see on this side, number of drugs, they were there as outpatient or 3 days inpatient. They go out with at least half the drugs. Here, 1, 2, 3, 1 when she went out. Then here, 1, 2, 3, 4, 5, 6, 7, 8. When they go out, 1, 2, 3 plus insulin. 1, 2, 3, 4, you can see almost 10 drugs. They go out with 5 drugs. And on that side, you find patient is asymptomatic, comes with body pain, no body pain. Everything disappears. In 3 days, when you 50% you cut the drug, 80% of the symptoms are gone. Next slide. So, in this is another very, very interesting case. 62-year-old man, hypertension, cardiac disease, diabetes of 20 years. Came for expert opinion, started as chest discomfort, etc. And he was taking so many medicines. When we admitted him, we cut down these medicines. Many of these medicines are causing the pain. The anti-cholesterol drug is one of the chief culprits causing body pain, muscle damage, muscle injury, and renal problems. So, without anything, he was comfortable and all his symptoms disappeared. Similarly here, you can see here, you can see here. You can see 1, 2, 3 drugs, 1 drug. Next, please. So, if you admit them, boldly take off all the medicines. Some medicines cannot be taken out very easily. They have to be tapered. That we are doing. And you will see a man 83 here. See, this man was 83, hypertension and asthma for 3 years. He came with a fast heart rate, taking all these medicines. Only one medicine which was cut off like that. And today he is perfectly all right. He was taking blood thinners, etc. Surely they all end up in hospitals. Next, please. So you can see this man, so many medicines. How we reduced it and how they improved. Next, please. Yeah, this is a man with prostatic carcinoma, 82. Was just noticed at 82, because he was getting some chemotherapy, his blood pressure shot up due to water retention. They immediately put 6 medicines for his blood pressure. We sent him out with 1 medicine, half tablet of that, and he was all right. Again, he went and had 1 more chemotherapy. Again, the same thing happened. Again, they put on that. So this is a thing where doctors should be educated. Doctors should be educated. So, as somebody said, if you do 10 Thopukaranams, it becomes all right. Next, please. Okay, the same thing. Come on. I think we can go. It's just to show you that any moment we can give you evidence. If you come and see our case records, they come in with about average 12 to 20 tablets. They go back home with 5 or 6, and then gradually even that is tapered off to barest minimum that is really required. Now, why is it that we should not give these drugs? I'll briefly give you the current evidence and then give you all relief from our lectures, because these are very important papers of recent origin which I want the doctor community to share, and I don't want the lay public to think that I'm against these medicines. Please do not think I'm against these medicines, but before giving these drugs, we have to think 100 times that it is absolutely necessary, and the duration and the dose must be monitored carefully by the doctor, and the patient should report to the doctor at the earliest for any side effect. These are very important. The first is the antithrombotic drugs, aspirin and its cohorts, clopidogrel and others. Now what this paper found is a Rotterdam study of a specialized type of PET scan, where they found those who took aspirin, about 60% of them had microbleeds in the brain and hemosiderin, and they had double the rate of Alzheimer's disease. And Alzheimer's we recognize by the plaques and by the amyloid. And here you will find that these things cause amyloid. See, aspirin and this may differently, cerebral amyloid angiopathy, a bleeding prone disease state. So these aspirin produced amyloid. So before giving aspirin, for a person who has had a heart attack, you have to give aspirin. For a person to prevent a heart attack, don't give aspirin. For a person who had a stroke, you can give aspirin for some time, but not forever. Similarly, there are rules and regulations for this, but once a pill, always a pill is our rule. Even here, the patients are also responsible. They say, how can I live without the pill? I'll get something. So the doctor prescribes it. Next, please. Hypoglycemia. I'm always worried about hypoglycemia. I'm never worried about hyperglycemia. I've never lost a patient due to high blood sugar. But low blood sugar, yes, particularly above 65. If you give too many drugs and don't have control over your patient's activity and patient's eating habits, you are sure that you are increasing the epidemiology and the statistics of incidence of dementia and Alzheimer's. So 3 attacks of hypoglycemia in an individual above 60, surely the risk of dementia is doubled. If the risk of dementia in the old age in that population is 1, if they get hypoglycemia 3 times below 50, the risk is exactly doubled, 100% more. So please be warned of that. Next, please. These are all papers to justify that. Then there was an Accord trial which bust the myth that tight control of diabetes does not cause heart disease, reduces heart disease. This is total bunkum. Tight control of diabetes does not reduce the risk of cardiac myocardial infarction or heart attack, nor does it prevent stroke. By doing tight control of diabetes 24 hours into 365 days throughout your life, you are only increasing the risk of mortality. You are not reducing the risk of mortality, but you are increasing the risk of mortality and Alzheimer's. This is the message that comes out of it. You can see it does not reduce the microvascular outcomes, and intensive control of diabetes is not appropriate for patients in this trial. That is the conclusion of this. They found a multi-million-dollar study. So this study threw a lot of bombshells. All the myth about diabetes causing stroke, diabetes causing eye disease, kidney disease, all this went fat. Because you want to reduce eye disease and diabetic kidney disease, you control them continuously for 365 days. Definitely it will be less, not because it reduces the microvascular disease, but patients die earlier. So you can't get more. Next. No, I'll show you. Intensive glucose control reduces some microvascular complications at the cost of increased mortality. It's not, I have not written it, Lancet. I have not written it. Okay? Despite microvascular benefits, Lancet authors conclude increased mortality makes aggressive HbA1c targets as imprudent. Please mark the word. Next. Now, 6-year mortality rate showed a very interesting data. HbA1c is a thing which we all say 3-year average of blood sugar, so you must keep it below 7. Otherwise, you will get complications. But when they kept it below 7 for 6 years, 25% of them died in 6 years. This is above 65. This is Accord study. When they kept it at a comfortable 7 to 8, only 17% died. So if you keep it tight, 25. If you keep it less tight control, it is 17.7. But if you don't control it at all, even then, less people died. Only 23% died. So by controlling, you are increasing the bhumi bharam korayum. Next. Hypoglycemia associated with death in critically ill patients. So in the ICU, I would suggest, unless the sugars are above 500, don't treat them. If you treat them, you are increasing your mortality. That's what this paper says. What is the optimal level of HbA1c in elders? Long ago in an IMA meeting, I said, different yardstick for different age group. Don't adopt the same yardstick for all age groups. In those days, people poo-pooed me and said, no, whoever it is, blood sugar must be under control. Today, American Geriatric Society comes and says that observational study in a large area found that HbA1c should be between 8 and 9 in the elders. Okay? Next, please. Then come statins. This is how I found, this is a very, very interesting thing, that these anti-cholesterol drugs, which we give statins for heart attacks and various other dyslipidemias, we call dyslipidemias. That means disordered fat in the body. Now this causes 9.5% incidence of diabetes. Incidence of diabetes means those who take statins for a long time, every year 9.5% will get diabetes. Now let us take 10 million people having this drug. Every year 0.95, that is nearly 1 million will get diabetes. So in 10 years 20 million will get diabetes if you take this drug. Okay. Today the incidence of prevalence of diabetes is about 32. In 10 years, they confidently, the people who give this drug can predict our thing will double. Because they know they are giving this drug and it causes 9.5. This is a very interesting study. Very interesting study. Okay. And then muscle injury. This is a Harvard study. People who had normal enzyme values were very normal. CPK enzyme is increased if muscle injury happens in statin. Such people, they found 2 groups of people, one with body pain, no statin, one with body pain with statin. Those who had body pain with statin, when they did muscle biopsy, 59% of them had muscle injury in the histopathology. Whereas in people who did not take statin, when they complained of body pain, it was because the wife beat him, not because of muscle injury. Next, please. Statins are linked with reduced energy level and also accelerate process. All these are papers. Next. And of course, this is what in the morning we said. Next. Of course, this is another drug called metformin, whose use can harm the kidney. Next. And that can cause also neuritis. Sometimes people taking this drug come with neuritis. They say, oh, it's diabetic neuritis. This paper clearly shows metformin neuritis is 30%. Diabetic neuritis is only 10%. So if you use a drug, you increase it by 3-fold. Next, please. Then the Journal of the Royal College, they came out with a special consensus in which they said so many things. When I asked them some difficult questions, a big group of doctors headed by Professor Roland Young, they said, we don't have any answers. This is our custom to give statins. This is our custom to give this thing. So you can write whatever you want. But what I wanted to tell you is that when I wrote to them like this, why is there a total lack of interest in doing credible research in the above points, is the glossing over of this important money-spinning drug as noted by so-and-so in the book due to any nexus between a pharma companies and the medical profession. This is exactly what I asked. They published this letter. They answered by saying, I just ignore your question. They didn't answer the question. Next slide, please. Then this is another new drug which is being given. It's called DPP-4 inhibitor. There are a group of drugs which starts from, they are talking about the salamander. The same group, the drug called XII, they started by saying incretin mimetic drug, then GLP-1 agonist. All these sort of names are given, and these drugs were given and found that they lowered the blood sugar beautifully by acting directly on the pancreas and modulating certain enzymes. And what they found was that they all increased inflammation of the pancreas for which there is no treatment. So, Girija says, you don't know the etiology. I know the etiology in many instances in this. You see, you stop the drug, everything becomes all right. But once the damage has occurred, you can't reverse it. So, pancreatitis is a very serious condition, and more recently, 2 papers have come which has damned these drugs. This class effect of these drugs called the GLP-1 and DPP-4 drugs. Next slide, please. So, 2 drugs for type 2 diabetes seem to raise the risk of acute pancreatitis. It doubles. The risk doubles when you give the drug. So, diabetes irundha oru complication irukku. Pancreatitis irundha rendu complication irukku. If I get diabetes, my risk for getting pancreatitis is 1. If I take this drug, my risk is 2, 100% more. Do we want those drugs? I just appeal to you. So, this has been confirmed by another doctor who had visited our department in 1994, Edwin A.M. Gale. Next slide. He says a concern that can be plausibly doubted or denied carries no legal liability, whereas one that gives rise to serious consideration leaves the door wide open. He compares it to the 3-monkey paradigm. Hear no evil, see no evil, talk no evil. So I'll end by saying I won't want to talk any evil. Next, please. This is morning. He showed you that some beta blockers can increase the risk. You see, they couch these studies are very interesting. They're done by drug companies. They will say if you give this drug, you reduce. See how these are called surrogate endpoints. You say, I am looking for a heart attack. You give a drug before a surgery to reduce blood pressure. After the surgery, what is the incidence of heart attack within 6 months or within 3 months? They found the study was classic. The incidence of heart attack was less. Then somebody extended the study and noted, again the same story, that heart attacks were less, but after 6 months, the incidence of stroke and death were double. No, this is the study poise. If you give this drug in that dosage before surgery and reduce it and continue it, after the immediate post-operative period, the heart attack score is less, cerebrovascular stroke is more, low blood pressure is more, and death is more. Mortality, double the mortality. Next slide, please. So this is same. Very, very interesting paper where authors did not know what happened. They did a study, they got the result, they found people who had taken this drug, particularly heart cases, non-heart cases, 7 times more death, and heart cases 11 times more death by taking this drug. But the authors say there is something wrong in our statistics. They don't say there is something wrong with the drug. They say something wrong with the design of the trial. They have spent money to design the trial and do the trial, swallowed all the money. Now they say we have to redesign the trial. I mean, this is all horrible. Next. So hypertension. Similarly, this is a very, very interesting. Hypertension in the oldest of the old. So among the 85 to 90-year-old, high blood pressure was associated with less cognitive and physical decline. That means if I have high blood pressure, I am less likely to become demented or to have physical decline. If I have low blood pressure, I will have double the chances of decline and double the chances of physical decline and cognitive decline. So high blood pressure is good for elderly. That is what it means. Next, please. Yeah, this is the last paper. I think 3:45. I have kept up my time, and I thank you all for your indulgence for staying this long. At TAG, we have tried to showcase whatever we have done in the last 2 years briefly during this time. You have got full half an hour or little more. Please relax yourself. Have a cup of coffee. and biscuits and come back at exactly 4:20. That little girl, Ayana Raman, did a beautiful dancing. Please don't miss that dance again, because she is going to do our invocation. Thank you very much for responding to our invitation. I am really beholden to all of you. Thank you, sir.